It's a great opportunity to talk about all the new treatments that are either have already arrived or in the pipeline for non-muscle invasive bladder cancer. The first one that has actually reached market, so to speak, is Pembrolizumab for BCG unresponsive patients. This is a checkpoint inhibitor, so it's immunotherapy given systemically. And the trial results have been presented a couple of times. And we see in patients with BCG unresponsive carcinoma in situ that there's approximately 41% complete response at 3 months that is durable out to a year overall in 19% of patients. So 19% are disease-free at 12 months. So this is fairly robust data, and it's already gone through the FDA in the United States and has been approved and is being used. So this is really the first new drug to cross that sort of finish line, so to speak, of FDA approval. There's a very similar trial looking at Adstildrin that has been reported early data that shows similar outcomes, but we don't have the same durability yet. Close behind Pembrolizumab are two other drugs that are given intravesically. One of them is Oportuzumab Monotox, which is also known by the trade name Vicinium. And it is an antibody-drug conjugate that is put into the bladder. It binds to EpCAM on the surface of tumor cells, and it delivers a toxic payload, so a Pseudomonas toxin, into the cancer cells, which is then released in the cell and kills the cell. This has been tested also in the BCG unresponsive population and has a similar complete response rate at 1 year of about 17%, so similar to the 19%. It is very well tolerated, very little toxicity. The Pembrolizumab, of course, has potential systemic toxicity since it's given systemically. The Vicinium basically causes some bladder irritation. The disadvantage of the Vicinium is that it's given so frequently. So it's given twice weekly for 6 weeks, once a week for an additional 6 weeks, and then every other week up to 2 years. So relatively high burden for the patient. And then the other drug, so of the three that are close to or at FDA approval is nadofaragene, which is also known by the trade name Adstildrin. And it's a gene therapy. So it's an adenovirus that is put into the bladder that introduces the interferon alpha-2b or 2-alpha-b gene into the bladder cancer cells. And again, this leads to cell death and clearance of the tumor. And in the BCG unresponsive CAS setting, same disease setting, same trial design, there's actually a 50% response at 3 months, so a little bit higher than the other two, potentially. It's always hard to compare between trials. And then 24% disease-free rate at a year. It also is very well tolerated. It's nice because it's delivered intravesically every 3 months, so very infrequent dosing. So we have these three drugs that are very close to approval or approved, and I'd say none of them are really home runs that are going to change the face of treatment, but there are clearly incremental benefits. And now we have a lot of work to do to figure out whether we can combine drugs, whether, how best to sequence drugs. Can we predict based on biomarkers which patients likely to respond to which drug? So there's a lot of work to be done. There are also additional drugs coming down the pipeline in this BCG unresponsive setting. And I touch on a couple of those in my talk. And then the next steps, of course, are also to go earlier in the disease spectrum. So to go from the BCG unresponsive patient who really has no good options other than radical cystectomy, to go to the patient who's had some BCG but is not BCG unresponsive. So that could be the BCG exposed or BCG experienced, the different names for that group. Or even the BCG naive, so patients who have high-risk disease but have had no BCG. And the trials that we're seeing evolve in those two settings, so BCG naive, BCG exposed, are mostly related to immunotherapy plus BCG. And it'll be interesting to see the BCG by itself is quite effective in the BCG naive patients. So it's going to be hard to show a benefit of immunotherapy, and it introduces potential toxicity very early in the disease course. And I'd say, just to finish off, the one other topic that I addressed in my talk is just that BCG itself is, works well. We like to complain, as urologists, we like to complain about the toxicity. Some patients don't tolerate it very well. But I think overall it works well, and it is a foundation of care in non-muscle invasive bladder cancers that we want to build on. We don't want to get rid of it, we want to build on it. And so there are a couple of trials that are looking at variations on how we give BCG with vaccination, different BCG strains, and also genetically modified BCG to see if we can improve upon it. So I think that's also an important point. But in summary, there's a lot going on. There are a lot of interesting trials. There are interesting drugs coming to market. It's all, I think, going to be beneficial for our patients. We just have to sort out now how to optimize care.